Hello, Assalamualaikum. So sorry for delay today. Okay, so let's start our today's class, and today we are going to discuss a very important module, which is data interpretation. It is a little bit smaller, you can say, module. So before going for recalls, let's quickly finish this data interpretation because this actually have so many values and these kinds of things you may have to be discussed before recall session. Okay, so let's start. In this data interpretation, actually, if you just see that these are the important topics for which you need to do all that, the calculation, the numbers. See the RMI score, you need to know APGAR, CTG, very important CTG, but not in very detail. Like you need to have a grip on for your MRCOG part 2. So it is a huge topic of CTG, but you need to do few important things. FBS interpretations, blood sampling, semen analysis, some points of miscarriage, hypertension, diabetes. That actually hypertension we have already discussed and diabetes also we have discussed. So hypertension, all those drugs which are required, the diabetes, again, those values which we have discussed previously, these are not included in today's topic. So if you remember the OGTT values, there are two values, how to diagnose. So these are actually important points which you need to do, and menorrhagia treatment as well. Okay, so first we need to cover, because this is actually the about ovarian masses. So basically we have two green top guidelines on this ovarian masses. One is for the premenopausal woman, like the young woman, and one is the postmenopausal woman. Okay, so they say now this is about the premenopausal woman, and this guideline is about benign. And do remember that you don't need to do the oncology. Oncology is purely a part of part 2, MRCOG part 2. Okay, so up till now, even only benign things you need to cover. Okay, and no, don't need to go into detail. So this is only you what you need to do. So whenever you have any ovarian mass, like any cyst, then you all know that we are going to do CA125, which is the tumor marker. Okay, now they say that if the woman is young, like premenopausal woman, not only the CA125 you do, but you need to do the LDH, the alpha fetoprotein, and also this HCG. Okay, so these things are also required, and this is only whenever you have a complex ovarian mass. See, not in a simple ovarian cyst. Only with this testing, these testing you need to do whenever there is a complex ovarian mass, and the features we will be discussing later on. And whenever you have a simple ovarian cyst, like there is a simple cyst of any centimeter. See, simple ovarian cyst, no need to do any kind of testing, even serum CA125. Okay, so whenever you get a question and you see that, and this is purely about the premenopausal woman, do remember by reading the question, if they say you that a patient is 70 years old, then she must be postmenopausal. So in 70 years, a 2 centimeter, if it is a simple cyst, then the things would be different. So if it is not a 70, if it is 40 years premenopausal woman, then 2 centimeter simple cyst, nothing to be done. Okay, so this you need to see. So CA125 not required in simple ovarian cyst, only required in complex ovarian masses, and also these three things as well. All these markers need to be done in premenopausal woman. Okay, so this is how we calculate the RMI. RMI is actually your risk of malignancy index. Okay, and it has three values. This is your CA125, then multiply by some ultrasound features. Okay, then multiply by the menopausal status. So CA125 is just the number which you get from the report. Like if you have a CA125 of 60, then just write it here. If the patient is premenopausal, then the score would be 1. If it is a postmenopausal woman, then the score would be 3. Okay, now the ultrasound features. So we have so many ultrasound features, like these 5 are total ultrasound features. Whenever you have, if one point is positive, one ultrasound feature, then you score is 1 score. Okay, and whenever you have 2 or more than 2 features, then your score is 3. Okay, there is no score of 2 in all these menopausal and ultrasound features. Okay, do remember this. Whenever the score 1 ultrasound feature, the score is 1. Whenever the score is 2 or more than 2, the score is 3. And do have a point of 0 as well. If there is no ultrasound feature, the score is 0 score. Do remember this thing. Whenever this ultrasound score is 0, then you know that whenever you multiply by 0, then everything would be 0. So your whole RMI would be 0. Okay, so these ultrasound features, you need to remember that if any time these features are present, like multilocular cyst, solid area, MAPS, and ascites and bilateral, all these 5 score, whenever you have no score, then the whole RM is 0. Whenever you have 1 score, this 1 feature, the score is 1. If score is the feature are 2 or more than 2, then the score is 3. Okay, so this is the whole formula, and this is the scoring we have done. Okay, so postmenopausal, the woman who is can be more than 40 age, and the postmenopausal, like for whole 1 year the periods are not present. So for whole 1 year it should be there. Okay, so sensitivity, specificity, there is number 7, 8, and 8, 7 is the RMI sensitivity. Basically, we do in premenopausal women, clinically we use these rules, B rules and M rules. This is called as aorta, which is the classification system of these ovarian masses. So B rules, whenever you have all these B rules, means benign rules. These features are present, you can say that these are benign features. So the cyst can be a benign one. If or any M rule is present, then you can say that the cyst can be a malignant one. Okay. So B rules are your unilocular, and here would be the irregular or solid tumor. Okay, so you can say that kind of a multilocular. Okay, but solid is there. Here the solid component can be there, but the solid component should be less than 7 mm. Okay, so this is actually the dimension, that this much solid component can be in the B rule. More than 7 mm or even 7 mm, this go to the M rule. Acoustic shadowing. Acoustic shadowing, like those simple cysts, they have the acoustic shadowing. So this is a very good feature. Like there is a cyst and there are no any kind of smooth solid component. Even a smooth multilocular tumor can be a B rule, but it should be less than 10 centimeter. Okay, less than 100 mm, 10 centimeter. And here the irregular multilocular, but cyst size is more than 10 centimeter, no blood flow and very strong blood flow. So these are the 5, and here ascites as well. So ascites and blood flow are always the M rules, and even the papillary structures are also the features of malignancies. Okay, so these B and M rules we usually do in the pre-menopausal woman. Okay, so this is the whole follow-up, that how you take the premenopausal woman. So we have discussed that whenever you have simple ovarian cyst, no need of CA1 to 5. This first thing you need to remember, no CA1 to 5 whenever simple ovarian cyst. Now there are 3 categories that you have simple ovarian cyst. That one is that you have not greater than less than 5 centimeter. Then you have a 5 to 7 centimeter cyst, and if you have more than 7 centimeter cyst. Okay, whenever you have less than 5 centimeter, nothing required, so no follow-up is required, so you can ignore this cyst. It would be your functional physiological cyst. If you have 5 to 7 centimeter cyst, then you can follow up with yearly ultrasound. Okay, follow-up is required, yearly ultrasound. And if it is more than 7 centimeter, then you need to do either further investigation, or you can go for surgery as well, because it is a larger one cyst. Okay, so this is how you actually follow up the patient. So you must see the question very clearly, that okay, what is the they have written, either it is a premenopausal woman, postmenopausal woman, what size of cyst, and even you have to see the symptoms as well, that she has no symptom, she's doing nothing to the patient. Okay, then you follow this chart. Okay, so coming to the postmenopausal woman, here we say that in postmenopausal women, even 1 centimeter cyst is very significant. You cannot ignore even 1 centimeter cyst. Okay, so this is very important. So whenever you see that because you know that postmenopausal ovaries are non-functional usually. Okay, so there is no need that the cyst should be there. So it is very important to see that. So here you need to go for CA125 first, and also the transvaginal ultrasound scan. So always, whenever you see a cyst in the patient, you have to do two things. One is CA125 and two is your TVS. So these two things need to be done. And for this, you can calculate your RMI score by doing this CA125 and TVS. And CA125, the normal range is up till 35. We consider it as normal, and this is raised in 80% of epithelial ovarian cancer. And because postmenopausal women have more chances of getting this epithelial ovarian tumor, so it is RMI is usually considered in postmenopausal women. Even some, because it can be raised, this CA125 can be raised in some other non-malignant gynecological conditions like any inflammatory conditions, or even some non-gynecological conditions. This can be raised. So there are many things which can raise this CA125. So you can say that it is a non-specific test, but you need to see other things along with that. If it is markedly raised, then you can say that it is due to CA. But if it is less than, like, the normal is 35 and your CA125 is just 40 or 50, then you can say that it is non-specific. So you have to rule out all other conditions, even endometriosis as well. Okay. Okay, so this is a very important flow chart for your postmenopausal woman. See, cystic lesion of 1 centimeter or more. So it is very significant. You need to do these two things, CA125 scan and calculate the RMI. So how you categorize the patient. RMI is less than 200 means low risk of having malignancy. And if RMI is 200 or more than 200, high risk of malignancy. So whenever the patient is high risk of malignancy, you need to undergo some investigations further, like the CT scan first, and you need to refer the patient for oncology review and even the MDT. Okay, so this is a different thing. So here, if you see that MDT review has high likelihood of malignancy, then you go for full laparotomy, the staging procedure by gynecological oncologist. But if you see that malignancy has less likelihood, but still you need to do a laparotomy and even all those clearance omentectomy, but it can be done by any gynecologist as well. Okay, so this is all about the malignancy, but you have to follow this thing because it is important for you. Low risk of malignancy. Now, first column, this, if this cyst fulfills all these 5 points, like all these 5 points are present in a patient, including these 5 points are that first, the patient is asymptomatic, no symptom. Okay, the second one is that this patient has a simple ovarian cyst. First, I told you that even a simple cyst is need to be investigated. So, but still you just write down these 5 points. The second is simple cyst. The third one is that cyst size is less than 5 centimeter. The fourth point is that the cyst is unilocular. It is not multilocular. And the fifth point is unilateral. So unilocular, unilateral. These 2 points, less than 5 centimeters, simple cyst, and there is no symptom. If all these 5 points are fulfilling, then you can consider a conservative treatment, including the follow-up by repeat ultrasound and CVS in 6 months. So first test was CA125 and TVS. Now again, you can follow up the patient by repeat testing after 6 months. If all these 5 points are fulfilled. If any of these 5 points are not fulfilled, like if there is a symptom, if the cyst is not simple, if size is not less than 5 centimeter, more than 5 centimeter, if it is multilocular, if it is bilateral, if any point is not fulfilling, then you have to consider surgery. This is very important flow chart. You need to remember this flow chart by heart. So whenever all these 5 points, then only you can consider conservative treatment, including follow-up. If any of these points is not there. Like the patient is symptomatic, cyst is non-simple, size is more than 5 centimeters, multilocular and bilateral, then you have to go for surgery. And in surgery, you go for bilateral salpingo-oophorectomy. Okay, not the TH is not required. Like hysterectomy is not required, but you need to remove the ovaries and tubes. Salpingo-oophorectomy is required. Okay. Okay. So in that, which was conservative treatment we were doing, like we have to follow the 6 months. If it is resolved, then you can discharge the patient. If it remains unchanged, see, those 5 features were there, but it is not resolved after 6 months, then again you follow up in further 6 months, and then you can go for either discharge or you can consider intervention as well. Only 2 follow-ups is you can consider. So one was this follow-up, and the second, if it is unchanged, then also you can consider this follow-up. If any change in features, then only you know that whenever the change in feature, then you go for surgery. So this is a very important flow chart, and you can get questions on this RMI score and also this postmenopausal symptoms. So these were 2 very important guidelines, and you just require this much knowledge for solving these MCQs. Okay. Okay. So APGAR, you all know APGAR. So you must know that how to calculate. So you have 5 total points APGAR, and total score is 10, and then you calculate 0, 1, 2. A is for activity. Activity means fully active patient. Active is 2. Then the limbs are flexed, and if there is no activity. Pulse, more than 100 should be there in the babies. If it is less than 100 or if it is absent, dryness is the reflex response. If response to stimulation is very good, minimal response or floppy. So 0, 1, 2, the appearance. See, the pink should be there. If pink with blue extremities is 1 score, blue and pale is 0 score. Respiration is the baby is crying. So cry is a good sign of respiration. Okay. Slow and irregular and absent. So even the cry, with cry, there is activity is very good of the patient, and even the stimulation response is there. So you can say that whenever the babies cry, then all these features can be fulfilled. But you have to see for the appearance as well, and even the dryness as well. Okay. So this is how you calculate the APGAR score. It is very, very important. And usually you get a question on APGAR score. So do remember this by heart, that how you calculate. Okay. Okay. So coming to the CTG. So CTG, you all know that it is a cardiotocographic representation. Okay. So in CTG, you have uterine contractions, you have a heart rate. Now for the baby heart rate, like this is how the CTG is there. So one thing is your baseline. If it is a 140 beats per minute, so baseline, you see one thing is variability. So variability is, if you just see this graph, you see that it is not uh, a static one baseline. It just change, it oscillates up down up down. So this is how we call it as variability. So it's a short-term variability or long-term variability. Some accelerations are there, and it has to be absent decelerations. So acceleration is, it has to, if you just see that this can be an acceleration, but for that I need to see that if it has gone for more than 15 beats per minute above the baseline and for more than 15 seconds. So this should be there for an acceleration, and reverse is for deceleration. So deceleration means the heart rate go down below the baseline heart rate, baseline for 15 beats per minute and for more than 15 seconds. So it can be like this deceleration. Okay. Okay, so this is actually a table of previous guideline of CTG. Now the CTG is also changed, so I have just correct these points. Okay, so first you need to know that how you calculate, how you categorize the CTG. We have features. Previously, you were reading about the reassuring features, non-reassuring, and sorry, abnormal features. Now these features are changed into red features. Sorry, not red. The normal features. then is the amber features, and then is these are the red features which were abnormal. Okay, so this is how we categorize is now. See this one. Now it is okay. Sorry. Now read it again. Okay, so these are normal features, or you can say that the white features. White feature. So it is actually color coded now. It's not normal. White, amber, and red. These are the three features now we have categorized. So white means if you know the CTG previously, then you can just say that, okay, the reassuring one is now white, non-reassuring one is now amber, and abnormal is now the red features. If you are new to CTG, then you can see that, okay, now the white features means the good one features are white, that these are the normal features. This should be there. So these are the normal one. Okay. And amber means you can say that these are some kind of suspicious features, that there can be some problem. And red is very bad. So abnormal feature is there. Okay. So normal, you have to know the normal. If you not know abnormal or amber, you must know the normal features. Normal is that the heart rate is 110 to 160 is the normal. Variability is 5 to 25 beats per minute. Acceleration and decelerations, you cannot say that there is no deceleration. There can be some early decelerations. There can be some variable decelerations. These I would recommend that don't go into detail of these variable decelerations. You cannot remember these things. Okay, so just ignore these decelerations. Just remember early decelerations can be here in the normal one. Okay. Okay, so this one was your white features. Now coming to the amber features. Amber means the one thing is the decreased. So here the heart rate is from 100 to 109. Okay, baseline variability is less than 5 beats for 30 to 50 minutes, or if it is more than 25. So not the variability should be less than 5 or more than 25. So here the time limits is important, that the CTG is for 30 to 50 minutes. If it is under 30 to 50 minutes, this can be an amber feature. If it is more than 50 minutes, this would be then go to the red feature. So this is how the time is very important, that for this much time, the variability changes from amber to red features. Okay. So usually they do not ask you very detail of this CTG, but you must know that this one is the variable, this one is the normal feature, white feature, which one is amber, and which one is red feature. So here previously it was written from 160 to 180. Now it is not written. Okay, so this is a change. So change is very important to remember, that this is now changed. So now above 160 goes to red. So more than 160 heart rate goes to red. Okay. Previously it was 1 till 180. So more than 180 was abnormal. Now they say that more than 160 is again abnormal. Okay, so this one was the red features less than 100 or more than 160. Okay, and variability less than 5. See, the time is now increased more than 15 minutes, and the more than 25 variability for more than 10 minutes. So this was just a time difference between the amber and red features. Again, I would say that don't remember these things, but acute bradycardia or single prolonged deceleration for more than 3 minutes. This you can remember. This is always a red feature. Okay, so how you these are the features. So first you know that, okay, which feature is like this is how you get the question. Like if you see a question, uh if I say that heart rate is 140 beats per minute, variability is variability is 3 beats per minute for 40 minutes, and there are some variable decelerations. I don't explain the deceleration. Okay, this is how you get the question. Now you have to categorize. Okay, 140 beats per minute, is it a white feature, amber, or red? Okay, so it is a white feature. This variability, 3 beats per minute for 40 minutes. So 3 beats per minute, it means it is not a white feature. It has gone now to the amber feature. So this variability, because it is for 40 minutes, if this I write that it is for 60-minute, variability is going down for 3 beats per minute, then this would be go to the red feature. So this thing you need to see that. So for 40 minutes, this variability is amber feature. Variable deceleration, or if you just skip this deceleration, you can skip that. Or if I said that, okay, there is acceleration or not. Acceleration, presence of acceleration, it has no, is a good sign, but absence of acceleration is have no significance, okay, uncertain that there can be acceleration. So if acceleration is there, it's a good sign, but absence is not, you can say that it's a bad sign. So if you just see that you have white feature, even the if you I say that there's no deceleration, so you can say that it is also a white feature. So you have 3 white features. Acceleration is also there, 1 2 3 white feature, and 1 is amber feature. Whenever you have 1 amber feature, the CTG will go to the suspicious one. Any one feature is amber, the CTG goes to suspicious. If all the white features are there, then it is a normal CTG. Any one feature is amber, CTG suspicious. Any one feature is red, CTG is pathological. Or you have 2 or more than 2 features are amber. This is how you categorize the CTG. So it means that the red features are very bad. If any one red feature is there, CTG is pathological. So next step would be the in the form of conservative management, that you have to first see the patient, assess the patient. If there is any, like in the form of hypotension, you hydrate the patient, you shift the patient to the left lateral position, you hydrate, give oxygen. These kinds of conservative management you have to do. You do the examination of the patient as well. After ruling out all these things, then you can see that if you have to go for blood sampling or not. So basically this blood sampling, whenever you get this pathological CTG, and this is a prerequisite of FPS, is that you have the cervix has to be dilated for more than 3 centimeter. So whenever you get the pathological CTG, it's an indication for blood sampling. And the contraindications are also there, that any maternal infection which can transfer to the baby, then you need to contraindicate. Any fetal coagulopathy, if the baby is premature, you cannot do anything. If there is acute fetal compromise, then you need to immediately deliver the baby. You cannot delay the by going into the blood sampling. So this is not any acute compromise is there. If it's any cord prolapse or abruption or any kind of this thing is there, then you have to go for emergency cesarean delivery. Okay, this is how you categorize. The normal pH is 7 point more than 7.25. So if you, because you have done FPS because of the pathological CTG, so pathological CTG was there, and what you do, you go for blood sampling. Okay, the sampling result is more than 7.25. It means it is a normal one, but you have to follow the CTG as well. So CTG, if it is remain abnormal like pathological, then you repeat in 1 hour. 60 minutes later, you have to repeat the blood sampling. If the blood sampling report is 7.21 to 7.24, which is a borderline one, then you have to repeat in 30 minutes. Okay. And if this is acidotic, like less than 7.20, which is a very abnormal interpretation, then you have to consider the delivery. Either if it is a fully dilated, then you can go for operative vaginal delivery, vacuum or forceps, or if it is not fully progressed, then you have to go for emergency cesarean delivery. So this is how you categorize, and you have to follow the blood sampling report. Very important. Okay, so coming to a semen analysis, we have, I think, discussed this. So all these values are basically very important. So volume is like 1.5 ml, pH 7.2. Basically, these points are important. Concentration 15 million. Like this is a cutoff. Above that is normal, and below would be abnormal. So this much is a normal things. Number is 39 million per ejaculate. Motility. See, whenever there is written motility, you have to see that either is a fully progressive motility or non-progressive motility. So 40%, Okay, so 32% or 40%. So 40% or more are motile, or 32% is progressive motility. So progressive one is just 32%. Vitality is 58%, that live sperms are there. Morphology is just 4%, normal sperms should be there. If 5% are there, it is normal. If it is 3%, then this is abnormal. Okay, so this much 4% is required in morphology. Okay, so this is about the menorrhagia treatment. You all know that menorrhagia is a very common disorder in women, and always the first line treatment of menorrhagia is your Mirena, LNG intrauterine system. But you need to consider that there is no identified pathology in the form of any fibroid, or because fibroid less than 3 centimeter and not causing distortion of uterine cavity, then only you can insert Mirena. Otherwise, if it is more than 3 centimeter or the fibroid is causing distortion of the cavity, then you cannot enter this, insert this Mirena. Or if you have the suspected or diagnosed adenomas. So adenomyosis is always a very first line treatment is always Mirena. If patient declines Mirena, then you can go for some oral management in the form of a non-hormonal and then hormonal. So non-hormonal including transamine and your NSAIDs, which include the progesterone 4, okay, mefenamic acid, and in hormonal you can go for oral contraceptive pills. So this much oral is you have to give. If all these treatment fail, then you can consider to other treatment. You have to refer to the specialist care as well, and you can go for endometrial ablation, or even the hysterectomy you can also go for. So these are the surgical and you can say the second line treatment modality. Okay, so hepatitis B infection. We have discussed hepatitis B in microbiology. So this is now we are just dealing with the question pattern, like how we actually solve the questions. So we have discussed all those antigens and antibodies. So HBs antigen, whenever it is positive, it means there is a infection is there. Okay, so if this antigen is positive, it means infection is there, either acute or chronic. If the antibodies to this is formed, anti-HBs, it means there is immunity. Now, immunity can be due to some past infection or can be due to some vaccination. Okay. Now coming to anti-HBC core antibody. If this core antibody is positive, it means that this patient is infected. So either can be a current or past infection. Okay. If this antibody, anti-HBC IgM is there, it means that IgM shows that it is a current infection. If this IgM is not positive, only this HBC is positive, then it can be a past infection. Okay. So if you just see these 4 lines, then you can say that in vaccination, what would be there? Whenever you vaccinated a patient and HBs antigen would be negative, this anti-HBs was always positive. Okay, but you see that it can be due to infection, it can be positive due to some past infection. So how you differentiate between an infection or vaccination? So that you will be differentiating by this anti-HBC. Whenever this anti-HBC is positive, you say that okay, this patient is infected either in past or it is now an infection. So this is how you differentiate between an infection or vaccination. So these are important points to remember. And even if you see this, okay, just remove all these points, and then this HBs antigen is positive in a patient. Now it means that it is a infection, acute or chronic. Now how to differentiate between acute or chronic? That this is a acute infection or this is a past infection. This would be differentiating by this IgM anti-HBC. If this IgM is positive, then we say that this is acute. If it is negative, then you can say that it is a past infection. So it means that would be a chronic infection. Okay. So I think with this, we have just ended our today's lecture, all those points, and just we'll be solving a few questions. So do send me the messages, your reply. of all these questions. So first, actually, about this HBS, we have just discussed. So let's read out. A patient 33-year-old and she has some deranged function test. Okay. See, HBS antigen is positive. Oh, and what is else is positive? These two things are positive. Okay. So HBS antigen positive, I told you that there is a there's an infection. Okay. So current infection is there, and current infection can be either acute or chronic. Okay, so this is negative because there is no immunity, so it is negative. Okay, so see these two, anti-HBC is positive, but IgM anti-HBC is negative. So what I told you previously, that how you differentiate between acute and chronic. Anti-HB, is positive. So C is just a non-specific. Okay, there is a positive, there is a past infection, but either it is acute or chronic. That we differentiate by this IgM. So if this IgM is negative, then what should be there? IgM is negative. What would be there? Either it is acute infection or it is a chronic infection. So what have you people tell me? Acute? Acute? How acute? Just tell me. Unmute yourself and tell me how it is acute infection. Okay, let's go to previous slide first and then tell me how it is acute. You have a question. This is positive and this is positive. These two things are positive in your question. Okay. Rest of all these things are negative. See, and IgM anti-HBC is negative in your question. This indicates recent infection. So if this IgM is negative, then you can say that this is not an acute infection. IgM is negative. This negative means it is no current infection, means not acute infection. It is a past infection. Anti-HBC just show that was an infection. So it means this was a chronic infection. Okay. So these immunity, acute, chronic. So whenever HBS positive, you have to select from these two options. So acute, chronic. Acute, whenever that IgM positive, then you say acute infection. If this negative, then it is a chronic infection. Okay. Okay, so this is a patient you have gone for fetal blood sampling and your result is 7.18. If you remember, I told you that the normal pH then is your 21225, then is your 7.20. So this was normal, this one your borderline, and this is your abnormal FBS report. And whenever you get abnormal FBS, 7.18 is very much less. It means that acidosis is there. Okay, so fetal acidosis is there. So you have to consider for delivery. You have to deliver the patient. You cannot wait for repeat CTG. So repeat in 30 minutes, 1 hour. These are not recommended now. Whenever you have pH less than 7.20, you have to immediate deliver the patient. Okay. Okay, so do tell me this question, that you just need to see that which thing is abnormal. Okay, if you remember those points of semen analysis. So progressive motility. Tell me this standard value. Sperm number, morphology, vitality, pH. Okay, who will tell me progressive motility, which is normal value? Progressive, I think 32% is normal and full motility is 40%. Yes, 32. 32 is progressive motility and progressive plus non-progressive is 40%. Okay. So still 35 is good. So total sperm number. How much is normal total sperm number? 39. Yes. Okay. Normal morphology is what? How much sperm should be normal? 4%. Good. and vitality is 58%. Great. pH is also normal, 7.25. Okay, so which thing is abnormal in your points? Only your morphology is abnormal. Rest of all the points are normal. Okay. Okay, so again a question about the fetal blood sampling. So here the blood sampling is 7.26. 7.26. It means this was your normal. More than 7.25 is a normal FBS report. But actually the previous CTG was abnormal. Now what you do whenever you have a CTG abnormal and your blood sampling comes normal, then what you do? You have to repeat this blood sampling in how much time? This is important to remember. There are two possibilities. You have to do fetal blood sampling in 60 minutes. D. Why you set D, or 30 minutes? You have two possibilities. 60 minutes you repeat when your fetal blood sampling is normal. In 30 minutes you repeat blood sampling when your fetal blood report is borderline. So here your report is normal. 7.26 is normal blood sampling. So here you go for 60-minute repeat blood sampling. So the option here is E. If this was like 7.25, even 25 is go to the borderline point. So then you go for fetal blood sampling in 30 minutes. Okay. So this was about the blood sampling. Okay, so aorta rule we have discussed. You just have to tell me malignancy point. Which is malignancy point? See if you just remember your B and M rules. Basically, these are about question is about BM rules. Unilocular is your B rule. Acoustic shadowing B rule. Solid component less than 7 mm is your B rule. Multilocular less than 10 centimeter is your B rule. Only blood flow is your M rule. Okay, so correct, very correct. This is your M rule. Okay, so now there are two questions about this, a miscarriage question about this question. I think I'll tell you in detail in my recalls, but just remember 2 points. First thing is gestational sac, then is the crown rump length. You can say like this. Okay, gestational sac, you have two possibilities that you get that in less than 25 mm sac or 25 or more than 25 mm. Okay, CRL less than 7 mm or equal or more than 7 mm. So these are the possibilities you can get question. Basically, they say that whenever you have a gestational sac of 25 mm, you must see a fetal pole. Okay, so this is a cutoff, they say. With 25 mm gestational sac, your fetal pole should be seen. But if you get a question that your question is that sac is 25 mm, but there is no pole, what to do? Sac is there 25 mm, but no pole. Then the NICE guidelines say that you have to repeat ultrasound in 7 to 10 days. Now here the difference is that if the scan was previous, then you have to go for the 7 to 10 days. If you are doing abdominal scan, then you have to repeat in 14 days, because NICE says that you cannot comment on one ultrasound. Always you have to repeat an ultrasound. Okay, same possibility is by this thing, the 7 mm. Same thing, less than 7 mm, they say that if it is 7 mm or more than 7 mm, fetal pole is there. See, CRL means that the fetal pole is there, but no fetal heart rate, no fetal heartbeat is there. Then again, the same thing. Repeat ultrasound in TVS for 7 to 10 days, in abdominal for 14 days. Okay, so this is the whole scenario about a miscarriage, they say. So then you have to, so when you get two ultrasound, then only you can say the label that this is not a viable pregnancy, this is either a miscarriage. On one scan, you cannot say anything. Okay. So here the cutoff always is your 7.6 mm. Already it has cut off 7 mm. But still, you don't have any possibility. You are not sure that after 1 week there would be a heart rate or not. You cannot label as miscarriage. You can say that this is an uncertain viability. So this miscarriage you cannot label on one ultrasound anytime. But they do say said that these are the miscarriage features. But I would not recommend you that you go for miscarriage, because I think this was written in your past MRCG, but in exam, because it is actually a very important guideline for MRCG Part 2, and they do give you a question on this thing, and they don't want you to select the miscarriage, because you cannot say on one scan that this is a miscarriage. Okay, so for that you have to have two ultrasound reports should be there. So always one ultrasound. If it is more than 225 mm or it is more than 7 mm, then you have to go for a second ultrasound report, or even you can refer for second consultant opinion. So for one ultrasound you cannot say anything. So it is uncertain viability, you don't know anything. Okay, do remember this thing. Okay, so again, this is a scan showing some echogenic mass, and sebaceous material is there, hair is also there. So likely diagnosis is what? So whenever you have all different kinds of germ layers, what do we say, that different derivatives of germ layers, that is your teratoma. Okay, so dermoid cysts, your mature teratoma is there. Okay, so this is again the same question here. This just mentioned that CRL is 6 mm. So always, whenever you have one ultrasound, then you always say that this is an uncertain, unknown viability. You cannot say anything. So basically, up till 6 mm, up till 7 mm, you don't know anything like it would be viable or no. Even after 7 mm, you need to get two ultrasound. If you have two ultrasound, then only you can say that, okay, this is a cutoff. If it is a 7 mm, no heartbeat. So if the next ultrasound is again 7 mm with no heartbeat, then you label it as miscarriage, missed miscarriage. Okay, so on one ultrasound you cannot mention anything. Okay, so with this we have ended our today's lecture, and this is all we have done in the data interpretation. We are just left with the stats for stats. Okay, so what do you suggest, that we should start from Wednesday recalls, or we should cover first stats, then you want recalls? This is up to you, because we can discuss recalls as well, because one paper we can discuss in this week and then we can do the stats, because I have collected the stats questions separately from those recalls, because stats was a very difficult one. So first we read stats, then we do those questions. Okay, so stats questions are a little bit separate from those recalls. So we can do recalls from Wednesday, and starting from I think 2020 paper we will be starting, and we'll be covering all the 5 years paper. So inshallah, from Wednesday we'll start with the recall session. Okay, if you have any suggestion, then you can give me. Okay, yes, great. Okay, so if you have any question, any query, then do let me know and do message in the group. And Dr. Bina, timing, yes, Dr. Bina, the timing, yes, the timing was left, because actually Dr. Khan said that 9 p.m. slot is not available on Monday, Wednesday. Only I think one day it was there. So I told them that if I can get 10 p.m. slot, so 10 p.m. slot is available. And so do tell me that 10 p.m. is good for you, because I am comfortable with 10 p.m. No issue. So 10 p.m. is okay. Okay. Okay, then great. Then, okay, the days are same and we can do 10 p.m. Okay, great. So no issue with 10 p.m. Then we can do the 10 p.m. Okay, I'll tell you in the group as well. The 10 p.m. So Wednesday, from Wednesday, 10 p.m. timing will be set. Okay. Okay, great. Okay, then good luck, all of you, and do revise all those previous things as well. Okay, do continue revising your modules. So best of luck and do prepare well. Okay, love this.